Contraception is the means to preventing pregnancy. There are many different methods of contraception available. However, just because a product exists doesn't mean it should be utilized. When determining which form of birth control is best to use, it's very important to consider the health problems, cultural influences, a patient's health literacy level, and the female's ability to follow instructions for use of that particular product. Women use contraceptives to make family planning easier. If the female wants to get herself established with education, degrees, entering the workforce, or simply trying to make a house or a home for herself, contraception gives her more control and the ability to plan for when she wants to conceive. However, contraception isn't 100%. About the only way to guarantee that there will be no baby is abstinence, or not having functional equipment, such as the woman who has completed menopause or has had a hysterectomy in which she doesn't have the parts needed to carry a pregnancy. Here you see listed various types of contraceptions. I jokingly say we refer to individuals who practice coitus interruptus as parents, as this method has a low success rate. It's important to remember that the clear, sticky, pre-ejaculate content that you see on the end of the penis contains sperm as well as the semen does, and the male doesn't have to ejaculate inside the female for the sperm to find their way in. You have to remember that these little swimmers have one goal in mind, and that's to find an egg and fertilize it. So if they just get close to an opening, they're going to find their way in. In the slides to come, we're going to discuss fertility awareness methods, barriers such as condoms, diaphragms, cervical caps. We'll talk about different hormonal methods with estrogen or estrogen and progesterone, or just progestins, and then the male and female sterilizations and lactational amenorrhea method. With fertility awareness, the female or the couple works and studies the female cycle to become aware of when the most fertile period should be, and then they abstain from intercourse during that time period. With the calendar method, the female maps her cycle for at least 6 months and determines what her longest days and her shortest days cycles turn out to be. She will then subtract 18 days from the shortest cycle and 11 days from the longest, and that will give her her fertile period. So an example, if her shortest cycle was 29 days and her longest was 32 days, her fertile period would be between days 11 and 21 in her cycle. With standard days, the women simply set a period of days as fertile, such as from day 8 through day 19, I could get pregnant, so I need to make sure that I don't have intercourse during those time periods. While this method may work for them, if you have a woman who has very long cycles or very short cycles, this can be more challenging because it's hard to set that specific timing interval. With the 2-day method, the woman simply asks herself, did I see secretions today, or did I see secretions yesterday? If she answers yes to either of these 2 questions, then she needs to either A, avoid intercourse completely, or B, use a backup method of birth control when she does have intercourse. If she asks these questions and the answer to both questions is no, she is probably not in a fertile period. Now, the ovulation method checks cervical mucus for changes in amount, consistency, and the pH to determine fertility potential. This method has also been referred to as the Crichton or the Billings method. You need to remember that other things can alter pH, such as certain medications the patient may be taking or douching, so patient education regarding these things is very important. Typically, once the patient has past about 4 days of the wet, slippery, sticky kind of mucus that we have talked about, her fertile period is over. When you're looking at basal body temp, don't forget we discussed needing a special thermometer, and they're going to graph it out, and what they're looking for is that temperature spike above 37 degrees centigrade. The basal body temperature testing is used in tandem with observing for symptomatic changes in the female, such as an increased libido, to help determine a fertility period. On the left you see examples of the male and female condoms. Notice how much larger the female condom is? It has a larger surface area that it needs to cover. The larger white cap that you see in the picture is a diaphragm, and the smaller cap is a cervical cap. Now, the woman will need to be fitted for a diaphragm, and it will need replacing at least every 2 years. If she has a weight change of 20% up or down, any pelvic or abdominal surgery, or carries a pregnancy beyond 14 weeks, she will need to be refitted for her diaphragm. Diaphragms are less effective without spermicide, so as a pretty important key teaching point with your patient that you need to remember. There can be a sense of spontaneity when a woman uses a diaphragm because it can be inserted up to 6 hours preceding intercourse. However, after intercourse, things may feel a little sticky and icky, so it's important that the woman understands the device must stay in place for at least 6 hours in order to be effective contraception. With both the diaphragm and the cervical cap, toxic shock syndrome is a risk if the devices are left in for longer than 6 to 8 hours, or if the woman uses them during menses to collect blood. Therefore, education regarding toxic shock syndrome and proper device use is critical for health promotion and disease prevention. You can refer to your textbook, pages 106 and 107, for detailed illustrations and information on the diaphragm insertion and removal. On the right side of the slide, you see the sponge. Not a product I've seen recently, but it was popular back in the early 90s. It was known as the Today sponge. For women who are breastfeeding, they don't want to take any type of hormonal contraception, and their partner doesn't want to wear a condom, this was actually a good alternative. Now, with the sponge, you wet it with water, insert it in. It needs to stay in place for up to 6 hours to be effective, and it actually can stay in place for up to 24 hours if there is going to be the potential for repeated acts of intercourse. However, keeping the sponge in for more than 24 hours will put the female at risk for toxic shock syndrome, so this is a key educational point. With combined oral contraceptives, a woman can get to the point that she knows exactly when her cycle is going to start and just about how long it will last. She can say, Tuesday morning at 9 o'clock, I need to be near a restroom or need to have products in preparation because my period's going to start. They can get just that specific. She can even skip cycles if she wishes with her provider's awareness and approval, such as if she needs to plan a vacation and doesn't want to have a period while she's on a cruise. Combined oral contraceptives can improve symptoms such as dysmenorrhea, acne, PMS, anemia, and other non-contraceptive issues for the female. However, taking the pill as directed is extremely important to the success of the pill. Each day, the woman should take the pill within a 2-hour window of when the first pill in the pack was taken. So say she starts her pill pack at 9 o'clock on Sunday night, then every pill for the rest of that pack should be taken sometime between the hours of 8 and 10 to stay within that 2-hour window. If the pill is taken outside of that range, patient may experience breakthrough bleeding, she may bring on a full-blown period, and she may even have ovulation occur. That's how women get pregnant on the pill. For women who can't remember to take the pill every day at the same time of day every day, the patch or the vaginal ring are viable alternatives. Limitations with the patch is for women who weigh more than 190 pounds, it's not recommended, or she may have an adverse reaction to the adhesive. The way the patch works is you put a new patch on each week, wear it for 7 days, do that for 3 consecutive weeks, and then the 4th week you don't wear a patch and you have a period. The ring is a flexible ring that is inserted into the vagina, and it kind of sits up at the cervix. The ring is left in for 21 consecutive days, and then it's removed for 7 days in order to bring on a menstrual cycle. The woman can leave the ring in place for intercourse, but if she or her partner are uncomfortable with the ring being in, it can be taken out. If she takes it out, she needs to make sure she rinses it off with warm water and dries it with a lint-free towel, and it has to go back in within 3 hours, or there's a potential for it to not be effective. The mini pill is used for women who wish to breastfeed and can't take estrogen because of the effects that it has on the breast milk and drying it up. The mini pill is a low-dose pill, and because it is, it's very important to take the pill the same time of day every day. A commonly reported side effect of the mini pill is irregular bleeding. Depo is the injectable progestin and should be administered every 12 weeks. Now, you know, there are some places that say every 3 months, but 12 weeks and 3 months are not the same time frame. So when I'm counseling patients and giving them education, I stress the importance of doing it every 12 weeks. Depo can be given as early as 10 weeks if necessary, and it can be given as late as 13 weeks, but again, 12 weeks is pretty much the standard. If you're giving the Depo IM, you're going to use a 21 to 23 gauge needle to deliver the 150 milligram dose. And you're going to administer in either the deltoid or the gluteus maximus. If doing sub-Q, then you can give it in the anterior thigh or the abdomen. Initiation of Depo-Provera is typically day 1 through 5 of the menses, menstrual cycle. If you're starting it postpartum, then typically you can start it within days 1 to 5 after she has had the baby. Long-acting reversible contraceptives such as Scala and Mirena are IUDs. Implanon is an implantable progestin-only medication or birth control option that is implanted into the upper arm. Scala and Mirena are intrauterine devices. Each device releases progestin continuously at low-level amounts and has a pretty high success rate, 99% and above, actually. But again, nothing's 100% except abstinence or not having working parts. Each type of birth control is inserted by a medical provider who has undergone specific training for that product. Scala has a 3-year lifespan, Mirena has a 5-year lifespan, and Implanon has a 3-year lifespan. Now, just because they are good for that many years doesn't mean the woman has to wait that many years to get pregnant. If she decides 3 years into Mirena she wants to get pregnant, then the provider would simply remove the contraceptive device, and fertility is going to typically return in about 12 to 18 months at most. The methods that we discuss here offer no protection against STIs, and pretty much the only protection against STIs that you're going to get is going to be with one of your barrier methods of contraception. Now, before placement of an indwelling device, a woman, especially IUDs, receives and signs informed consent, has a negative pregnancy test, has no evidence of cervical cancer, and is negative for any sexually transmitted infections. Non-hormonal IUDs can be in place for up to 10 years, yet they have more association with heavy, painful periods, especially in the first year of use. But for women who can't take hormones of any kind, a non-hormonal IUD, such as the copper T, is a very viable option. The LAM, or lactation amenorrhea method, is controversial depending upon who you're speaking with. For success, the woman needs to exclusively breastfeed. Very important point. This means no supplementation of any type at any time. She may pump, but pumping needs to be done frequently, and it needs to be done completely. The premise with the LAM is that prolactin that's released with breastfeeding is going to suppress estrogen, and the suppressed estrogen is going to prevent ovulation. Therefore, a woman needs to be feeding at least every 4 hours in the day and every 6 hours at night. So the woman who excitedly shares with everybody, hey, I got a good night's sleep, the baby slept 8 hours without waking up to be fed, is probably not a candidate for the LAM. Now, we think of sterilization as permanent. However, these procedures can be reversed, and they're not 100% guaranteed. The success rate is practically 100%, but there is still a plus or minus 1% failure rate. If a woman is going to have a bilateral tubal ligation, it can be done laparoscopically pretty much at any point in time she wants to, or she can do what we call a postpartum BTL, which is performed within 48 hours of delivery. That procedure is done through an incision in the navel. The uterus, the top of it, the fundus, is about at the level of the belly button, and the tubes, fallopian tubes coming off of it, make it easy for the surgeon to just make a little incision in the belly button, fish out the fallopian tubes, cut them, tie them, and then put them back again. Now, either a postpartum bilateral tubal or a laparoscopic bilateral tubal requires hospital admission. The laparoscopic requires general anesthesia. The postpartum can be done under general or epidural anesthesia if the woman still has her epidural catheter in place. The vasectomy occurs in the doctor's office, and it is done under local anesthetic. The male scrotal sac and area is cleaned and prepped, and then the provider uses local for anesthesia, makes a little slit, the vas deferens is identified, it is cut, and it is tied. Now, the male should have at least one, preferably 2 samples of sperm-free ejaculate before he can stop using a backup method of contraception. For about 3 months, maybe even a little bit longer, there will still be sperm alive in the proximal vas deferens. So it is important that the man do his follow-up and do his semen analysis to make sure that he is indeed sperm-free before he goes to having contraception-free intercourse again. Both of these procedures, tubal ligation and a vasectomy, required informed consent. Abortions are difficult to think about, and they're difficult to work in a lot of different ways. As a nurse, it is important to understand, to know, to recognize, and to deal with your own feelings and prejudices about abortion. If you are 100% anti-abortion, regardless of the who, what, where, whens, and whys, then maybe you don't need to put yourself in the situation to care for those patients, because you may not be able to give them the best care possible. And that's okay. You need to recognize that, because we have to go in supportive and non-judgmental. It's important that we are able to talk with our patients about expectations pre and post procedure, what type of comfort measures to use afterwards to help her get over this, and definitely talk about the use of birth control and follow-up with their provider. Induced abortions are those that purposefully and intentionally are made to have happen. Any abortion is a disruption in pregnancy before 20 weeks. You can have an elective abortion, which is where the individual simply chooses to not be pregnant for whatever the reason. It was an unplanned pregnancy, bad time. There could have been an assault, a rape or an incest, or something like that, and they just choose to terminate the pregnancy. Therapeutic abortions are typically done when there is a genetic disorder or a life-threatening circumstance that would cause harm for the mother, and or the fetus would not be compatible with life were it allowed to progress. Abortions have been controversial since the beginning of time, it almost seems like. There is always going to be a debate on whose right to choose is it? Can we have this done? Should we allow it? Are you terminating a pregnancy? As I said in class, we say a pregnancy has to go at least 20 weeks before there's even a remote chance of viability outside of the uterus. Yet, for women who choose to terminate a pregnancy at 8, 10, 12 weeks, then we're saying you're killing something. There's a lot of social stigma and a lot of individual beliefs and practices that play into this. If you are caring for a woman, whether it's an elective or therapeutic abortion, you need to remain non-judgmental, provide education to help her recover from the process that she's undergoing, and be very, very supportive. If a woman has a first trimester abortion, if it is a spontaneous abortion and she loses the pregnancy naturally, then it's important that all of the products of conception are evacuated from the uterus. So she can have a D&C done if she loses the baby naturally. If it is an intentional abortion, then they will do a surgical aspiration abortion and go in and remove the intrauterine content that way. Medical abortions are done with medications, methotrexate, and those are used on your ectopic pregnancies because you can't go in and suction aspirate that out. If you're going to do it any other way, surgically, you would have to go in and do a laparotomy and do a salpingotomy and go in and try and remove the embryonic tissue that way. Your second trimester abortions are referred to as D&Es, or dilation and evacuation. These are not easy to do. I've actually spoken with providers, physicians I've worked with that has only done a couple of them because they're not commonplace and they are not fun to do. And I don't mean fun, haha, but it is difficult to do those. The woman does have to have more cervical dilation because you've got larger products to remove now, and it's not going to be as easy as putting a small suction curette inside. You have to actually get cervical dilation going. With your patient, you need to assess for grief and facilitate the grieving process if necessary. Somewhere around the range of 70-75% of women, when there's an abortion, they feel like they have lost a child, and so they do go through grieving. And then the remaining percent just see it as an event. They did not have a maternal attachment to the pregnancy, so they may not have the need for facilitating the grief process. After a woman has had a suction D&C, it's important to explain to them the things that they need to watch for and what they can and can't be doing. Pretty much nothing should go inside the vagina until everything is cleared up and all discharge has stopped. We don't insert tampons, we don't have sex, we don't douche to clean things out, because you want to keep an eye on what is coming out, be able to evaluate the discharge and make sure there's not any changes, any potential for infection. You want to make sure they're not having fever or chills, that they're not bleeding and saturating pads within an hour, they're not passing large clots. If any of those things are going on, they need to call their provider right away. Menses is not going to be an absolute guarantee that on week 4, day 1, it's going to start. It's typically going to be a range of about 4 to 6 weeks. Women can start birth control after they've had a D&C because it's pretty safe to say they're not pregnant, so you don't have to worry about any impact that the hormones would have on a developing fetus. IUDs can be inserted immediately. Your hormonal contraceptives can be started immediately up to 1 week. After that 1 week, then you've got hormones that are already getting a follicle ready and getting ovulation ready, so you may have to delay starting it after that. And again, make sure your patient's aware of any complications so that she can report those to a provider and prevent a bad outcome. When you're using methotrexate, patient teaching for this is very important. The way methotrexate works is to block folic acid in fetal cells. So if a woman has been pregnant, we tell them preconceptually and during pregnancy to supplement with folic acid. Well, if they're taking folic acid, then it can interfere with the efficacy of the methotrexate. So they need to make sure they're not taking any folic acid supplementation. The misoprostol is a prostaglandin that's going to work to cause cervical softening. It helps the cervix open up a little bit. And remember, we talked about how it works on smooth muscle and causes contractility, so it will help the uterus start contracting and expulse the intrauterine contents. So with the methotrexate, it can be given either IM or PO up to 7 weeks after the last period. You'll give it that, and then 3 to 7 days after they get their methotrexate, they will do the misoprostol, and it can be done at home. You're going to follow them up after that, and you're going to confirm that they did completely finish the abortion, whether it's with serial HCGs to look for the hormones dropping, do an ultrasound to make sure that there's no retained products of conceptions. If the AB was not complete, they may repeat the dose of the methotrexate, or a lot of times providers will just go ahead and do a D&C. Now, the mifepristone, formerly the RU-486, has been approved since about 2000. It binds with progesterone receptors, so if they're taken up, then the pregnancy is not going to be able to develop and to grow. Typically, it is allowed up to 8 weeks after the last menstrual period, and the follow-up for that will be in 2 weeks. Now, changing gears a little bit, we've gone from contraception, now we're going to look at infertility. About 10 to 15% of reproductive aged women and couples are going to be affected by infertility. As women get older, obviously the risk of infertility has been seen to increase. And think about the population like we talked about. Women are waiting until their 30s or even 40s to start trying to have children because they want to get themselves settled first, and the longer they wait, the higher their risk for having fertility issues becomes. Diagnosis and treatment of infertility does require a lot of investment, and it will be physical, emotional, and financial. Infertility and the testing and all the steps that is gone through can be very tough on couples, and the stress has actually damaged relationships in the past. Things that we look at associated with infertility are the reproductive tracts functioning, or have they developed appropriately? Are the hormones working the way they need to? Does the man have sperm in his ejaculate? Does the woman have eggs even? How many follicles do we see? And then, as always, there's going to be some piece of the puzzle that is unexplained, and we do have the idiopathic infertilities. If you refer to Table 4.3 in your book, that kind of goes over the assessment of your female when we're looking at infertility management. Basic, non-invasive assessment is going to begin with asking her, are you having periods? When was your last period? What are your periods like? If a woman is not having a period, she's not ovulating. If you're not ovulating, you're not going to get pregnant. So just basic, ask her what her menstrual cycles are like. Has she ever had surgery on her uterus? Has she ever been told her uterus is abnormal in any way? Does she have fibroids? Get that information from her. Then your provider is going to do the diagnostics to, check hormone levels. Does she have FSH and LH appropriately? What's her thyroid doing? Do an ultrasound to look at the ovaries and see if there is evidence of PCOS. Check the endometrium, see is it proliferative and supportive of a pregnancy. an HSG or histosalpingogram will actually inject dye, and the provider can track it through with radiology to watch the dye to make sure it is patent from the cervix, which is the opening into the uterus, through the fallopian tubes, and out, to make sure there's no scarification that could cause the infertility. For your male, semen analysis. Everybody knows about that first and foremost. We want to see, do we have swimmers and are they alive? Then they will check the male hormones and possibly do a testicular biopsy. Depends on who you talk to about the postcoital test to see, is that even worth doing anymore with all the new advances that we have. That's a test that's pretty much gone by the wayside. As I said, infertility and all of the things associated with management, workup, is pretty hard on couples. It's a financial stressor. It can be it's your fault, it's my fault, I'm inadequate, you're inadequate. It can put a lot of stress on the psychological aspect and your ability to be social with others, especially people maybe who have babies and you're trying so hard. Sex can become a chore. Instead of being a way to connect and relax with each other, it's now just another one of those things you have to do, and that can be very detrimental to a couple's relationship. So you have to be able to discuss openly with your patient, offer counseling, tell them to just get away, take a break, don't have sex or something like that. Anti-sperm antibodies have actually been shown to interfere with the woman being able to get pregnant because it attacks the sperm and fights them off. So what the woman will do is, for 6 to 12 months, they will use condoms, okay, so that there is no contact with the male sperm. The only time they would go without condoms is during the ovulation period, when you're actually trying to get pregnant. And the thought is that if you've been shielded from the sperm, you should not have antibodies to fight with the sperm, so theoretically you would be able to get pregnant. And they do have about a 33% success rate for the couples that do this. Table 4.4 on page 128 in your book lists out your medications. Clomid, the clomiphene citrate, is a very common medication that is used to induce ovulation, in the hopes that if I have the eggs coming out, one of them will get fertilized. It is not uncommon for women who do Clomid to have multiple gestation pregnancies. Your metformin is utilized in infertility because it does help restore the ovulation in women with PCOS. So just read over the table in your book and familiarize yourself with these medications. For couples who are beyond the lifestyle modifications, non-medical interventions, and beyond the medicines that were noted previously, artificial reproductive techniques include in vitro fertilization, where they take an embryo and actually transfer it into the uterus. Now this one has the kind of catch-22 associated with it, because typically you're going to implant or transfer more embryo than what you want. If you want a baby, if you just put one embryo in, you don't have a good success potential. But if you put 5 in, there's a really good chance 1 or 2 of those are going to take. The rub comes in when all 5 of them take. What are you going to do with them? That selective reduction in pregnancies, that's a hard thing. So women who undergo in vitro need to be aware of what potential risks and decisions are going to be associated with that. Your gamete intrafallopian transfer is pretty much what it says. They take an oocyte, they combine it with washed sperm, and put those together immediately in the fimbriae to let them come together and fertilize and traverse through the fallopian tube. Your ZIFT, zygote intrafallopian, transfers things that are in a zygotic stage, and then your ovum transfer has your donor oocytes inseminated and transferred to the recipient. Other ARTs are embryo adoption, where you actually have someone donate embryos and those are transferred into the recipient. You have your donor sperm insemination, which you probably are a little bit more familiar with. One sperm injected directly into the egg and then utilized with in vitro fertilization, and then assisted hatching, where chemically or manually you penetrate the zone of pellucida, hard word to say, to create an opening for the divided embryo. And then to finish up, we have to consider the complications. Again, your multiple gestations. What are you going to do when you put 5 in and hope 1 or 2 takes and you wind up with all 5 taking? When you're doing the intrafallopian transfers, does it go all the way to the intrauterine cavity and implant there, or is there's a higher risk association that it may implant somewhere along the path of the fallopian tube and become an ectopic extrauterine pregnancy? It's hard to make decisions to know what you're going to do in these situations. And there is something to consider with pre-implantation genetic diagnosis, to look at your embryos to see if there's the possibility of any genetic defects existing, and you can know that before implantation ever occurs to determine, am I even going to use that embryo or not? There are many children without parents and many parents without children, so adoption is always a viable option for couples who do suffer from infertility to be able to consider. And then you may have a man and a woman who have functioning ovum and sperm. She just, for whatever the reason, can't carry a pregnancy to term. So you could employ the use of a surrogate, have a surrogate carry the fetus to term, and that way when the child is born, it will be genetically the parent's child. The parent did not carry it to term because of a personal reason, a health reason, whatever the reason. But those are the different methods for assisted reproductive techniques that we have. So that concludes the balance of the lecture from week 1, and we will review this on Monday the 24th to see if there's any questions. Thank you.